Welcome back, Titans, to another episode of EMS Lecture Series. Today we are going to be talking about XABCDE. After your scene size up, this is going to be the assessment of your patient, and it's going to be part of the primary assessment. Now, typically, we use ABCDE for most patients. However, in two cases, per Nancy Caroline, we are going to use X in the presence of blood loss, or CABDE for an unresponsive patient that we would assume is in cardiac arrest. However, for today's lesson, we're going to include the X, which is for exsanguination, so you get the whole realm of all the different items. So, like we said, X is exsanguination. This is clarified as a severe blood loss in a patient. This is coming up to a patient and identifying that there's blood on their shirt, their pants, an excessive amount of blood, or uncontrolled bleeding that we are going to have to stop. It's important to notate that in this process of XABCDE, we cannot move on from one to the other until the first item is fixed, then the next, and so forth and so forth. So if you're on scene with your patient, we start with X, exsanguination. We do not move on to airway, breathing, circulation, disability, or exposing our patient until each one is fixed. So when the heart is unable to pump sufficient amount of blood, it cannot perfuse the tissue. That is our concern. Obviously, most of our agencies and most jurisdictions don't have whole blood, which is the best for replacing blood loss. So we need to fix that. This can be done with direct pressure, elevation, bandaging, ABD pads, or tourniquet for severe arterial uncontrolled blood loss that we need to stop. Moving on to A. A is our airway. When it comes to assessing the airway, and keep in mind all of these things should happen pretty quickly when you're doing your primary assessment of your patient. We need to know, is the airway open? Is it patent? And will it remain so, or is there a risk that you may lose the airway? Is there swelling, foreign body airway obstruction? Is there liquids or secretions in their oropharynx or their airway that's going to prevent them from being able to breathe appropriately? Are they talking or crying? Now, Nancy Caroline says this is a very good indicator for our patients that they have an airway. Do we need to do a head tilt chin lift or a jaw thrust to open that airway for them? Do we need to use an adjunct, OPA, NPA? Do we need to provide some sort of maneuver to keep that patient's airway open? Also, you need to consider, do I need to take the airway? Do I need an ET tube, a King, an LMA? Do I need to control that patient's airway for them? If not, we move to B. So we've talked about exsanguination. We've assessed the airway real quick. Now we're going to move to breathing. You can pretty much assess the breathing of a patient regardless of the patient's age. Either a geriatric patient, an adult, adolescent, newborn. Either way, are they breathing or not? These are the two main questions. Breathing or not? Is it adequate? We need to look for rate, rhythm, and quality. So, the rate. Typically, when you're assessing a patient's breathing, you can either hook them up to a monitor, but always the manual assessment of how they're breathing and the rate in which they're breathing is the best, at least for your initial assessment. I'm going to count how many breaths per minute that patient is breathing. That's going to be your rate. Now, it says that the minute volume is the amount of air moved in and out of the lungs each minute. This is the best measure of breathing adequacy. What's the rhythm like? Is my patient taking normal breaths, say 2 seconds in, 2 seconds out, and is that consistent? Do they have irregular rhythm of breathing? This could indicate a diabetic emergency. This could head trauma. This could be a number of different things that we'll go over in another video. And then the quality. Are they breathing? Are they getting good tidal volume, equal chest rise and fall? Are they using accessory muscles to breathe? Do I need, if one of these is a problem, do I need to consider putting my patient on supplemental oxygen or positive pressure ventilation? Do I need to use a BVM with oxygen? and assist that patient in breathing to give them more oxygen, to give them more tidal volume. If we're still good with X, A, and B, we're going to move over to circulation, which is the heart. Now, in most cases, the best place to check for a pulse in a responsive adult patient is the radial artery. However, you may use the carotid in an unresponsive patient. You can use a brachial in a child, and so forth. What we're going to do is hold that radial artery for about 30 seconds because we want to calculate the patient's heart rate. So after 30 seconds, I'm going to times it by 2, and that's going to give us our beats per minute. Say our patient had after 30 seconds was 42. We're going to multiply that 2, and that's going to give us 84 beats per minute. Now, in some cases, if you have an irregular heartbeat or an irregular pulse rather, and it feels irregular, it feels weak, it feels bounding, you may have to increase this to 60 seconds to give you a more adequate number on what your actual beats per minute is. After we've identified the circulation of our patient, you can also, while you're grabbing a radial, feel for the skin temp and condition. Are they diaphoretic, which is sweaty? Are they pale, which could indicate poor perfusion? Is that patient's skin flushed, which could be from a number of different things? Is their skin very hot, which could indicate they are febrile or maybe septic? But we're going to move on from XABC. Now we're going to move to disability. What is disability? Now that we've assessed our other things, we're going to do a quick neuro exam. Emphasis on the quick. This all should happen very, very quickly. Part of that is AVPU, GCS, and I'm also going to look at my patient's pupils. AVPU, is that patient alert? Do I need to speak to them to verbal? Are they alert to verbal? Painful stimuli, do I have to give them a sternum rub? Or are they unresponsive? This is important, especially during your primary assessment. In your beginning, you want to have a baseline of where that patient is as far as their initial neuro exam, because it could change throughout the call. So we should have a good idea of how they are when we started with them and how they are when we finished with them and drop them off at the ED. Then we're going to move to GCS, Glasgow Coma Scale. You can see the breakdown of the GCS in another video that we have on our page. And then we're also going to assess the pupils. Are they equal, round, reactive to light? Are they sluggish, constricted, dilated, all that? And we're basically checking for any deficits. We're also going to check for the extremities. Do they have equal grip strength? Is the patient confused? Can they only lift one arm? Do they have facial droop? Anything that is out of the typical norm. Now, a quick tip for this, if you have a family member, a good historian on scene, ask them what the normal mentation or normal neurological function of that patient is. Because even if we have a GCS, let's say of 13, this may be the patient's norm. So that's their baseline. After we've identified disability, we're going to go to exposure. Big thing, we want to expose, then cover our patient. Not every patient needs to be completely exposed to perform an adequate assessment. Say I have a patient with abdominal pain. It is essential to the physical exam process that I expose that abdomen. I'm feeling all 4 quadrants. I'm feeling for rigidity, tenderness, pain, swelling, or looking for any obvious decap BTLS. However, once we complete our exam, we need to cover that patient back up. We can give them a blanket. We are trying to help with the patient's dignity, and we also want to provide warmth. So you expose, then cover. After all these things are said and done, that is the end of your primary assessment. And now we have a good idea of what our transport decision is. Hope this helps. See you next time.